సాటర్డే అనేసరికి జనాలు
అదే
అంటే థర్స్డేకి అలవాటు పడ్డారు కదా సాటర్డే అసలు ఉందో లేదో అని కూడా కొంతమందికి
అంటే జస్ట్ అందరూ హాలిడే మూడ్ లో ఉంటారు కదా.
మనకేంటన్నా హాలిడే?
మనకి ఏం లేదు, హాలిడే ఏం లేదు. ఆ మూడ్ వస్తుంది అంతే. ఏదైతే ఈ ఐటీ ఏరియాలలో ఉంటే ఆ మూడ్ వస్తుంది అంతే. మా అపార్ట్మెంట్ దగ్గర డెజర్టెడ్ ఉంటది, డైలీ జామ్ ప్యాక్లు ఉంటాయి. ఈరోజు డెజర్టెడ్ ఈవినింగ్ మెల్లగా నిదానంగా 4 o'clock బయలుదేరుతారు జనాలు. ఇక మళ్ళీ
ట్రాఫిక్ ఉండదా సాటర్డే?
తక్కువ ఉంటది అన్న. ఇక మేము ఉండేది గచ్చిబౌలి ఏరియాలో పక్కా ఇది సాఫ్ట్వేర్ ఏరియా కదా,
బాగా తక్కువ ఉంటదా?
చాలా తక్కువ ఉంటది. అసలు ఉండరు, ఎవడు కనిపించడు 4 వరకు, చాలా తక్కువ.
ఫ్రైడే నైట్ తాగేసి పడుకుంటారు అంతే కదా?
లేదన్నా అలా కూడా బాగా ప్రెషర్ ఉంటది కదా, వర్క్ ప్రెషర్ ఎక్కువ ఉంటది. మనకి ఏంటంటే వాట్ ఈజ్ ఇన్ ద సాఫ్ట్వేర్ సిస్టమ్, నేను మా కజిన్స్ తో మాట్లాడుతుంటే వాట్ దే ఆర్ సేయింగ్ ఇస్ what software systems used to run, now hospitals are running in the similar models now. వీళ్ళు 20 సంవత్సరాల కింద చేసేవాళ్ళు, now hospitals are running in that way.
అంతే కదా, టార్గెట్ అచీవ్మెంట్.
అదే స్టార్ట్ చేద్దామా?
ఓకే అన్న.
Good morning everyone. So sorry we could not present on Thursday. Today let's go with the topic acute liver failure. So in this acute liver failure, this topic is basically presented by Dr. Manoj Kumar Rai during the session of STEP. So we are not discussed in our Morton group, so I thought we'll take up this case. So introduction, it is a severe and complex condition, results from acute and massive hepatocellular destruction, has a very poor prognosis and approximately 80% mortality. You all know better, in the intensive care unit we see most of some of the liver cases, and these patients even prognosis also is very poor. A better understanding of cause of acute liver failure, the specific treatments, improvements in intensive care unit and liver transplantation dramatically improve the prognosis of patients with acute liver failure. With liver graft has 1 year survival of approximately 65 to 70%. So incidence of 8 cases per million. So it is not very significant incidence. It is 8 cases per million. Mainly affects young adults, peak age is between 35 and 45 years. We are not, so please remember, women accounts for approximately 60% of cases. So please remember that we are not discussing about the patients who are having a chronic liver disease. We are discussing about the patient who is having an acute liver disease. The classic description of acute liver failure is involves the abrupt loss of hepatocellular function in a patient with previously normal liver function, the expression of which includes coagulopathy and hepatic encephalopathy. So both the coagulant factors are depleted and hepatocellular function is depleted. So both leading to the hepatic encephalopathy, and also it's a coagulation abnormalities in this patient. So in a patient with acute setting of acute hepatitis, abnormal liver synthetic function, INR of more than 1.5, and development of altered mental status and hepatic encephalopathy within 26 weeks of the onset of illness in a patient without a history of liver disease. So he doesn't have a history of liver disease, but within the 26 weeks, that is approximately around 6 months, it is called acute liver failure. So for this classification, there are multiple classifications are there. O grade system, it's a hyperacute liver failure is within 1 week. So usually we see with the toxins and drug abuse, drug toxicities, we see this hyperacute. And hyperacute is one of the condition where these patients go into deep encephalopathy, and they are the indication sometimes for acute liver transplantation. So these patients are given the top priority in the acute liver transplantation as per the Jivandan group committee. And the acute is up to 4 weeks from jaundice to encephalopathy, and around 12 weeks in the subacute system. And Bernard system is a fulminant hepatic failure. So here it is around 2 weeks, and subfulminant is approximately around 12 weeks, 2 to 12 weeks. Japanese systems is a fulminant hepatic failure from 0 to 8 weeks and late onset. And also they have a acute and subacute, which is approximately 10 days and after 10 days to 8 weeks. This is from the jaundice onset to the encephalopathy. So there are multiple reasons why these patients will have etiologies. So acetaminophen intoxication. So this is a condition we rarely see in India, but this is one of the most common condition in US and UK. And hepatitis B, C, and E, we do see a lot of patients with hepatitis B, and sometimes we come across with hepatitis E also. CMV, Epstein-Barr virus, HSV, varicella zoster virus, and autoimmune hepatitis, Wilson's disease, Budd-Chiari syndrome, drug-induced liver injury, Amanita of phaloids intoxication. This is a mushroom which can cause acute liver toxicity, acute fatty liver of pregnancy. So this is acute fatty liver of pregnancy is also one of the rarest condition. And HELP syndrome, we commonly see this HELP syndrome, eclampsia, preeclampsia, and HELP syndrome, and ischemic hepatitis. Especially ischemic hepatitis patients with post-cardiac arrest, we see this. So worldwide causes of acute liver failure. So if you see here, in UK it is acetaminophen toxicity, and even in US also it is acetaminophen toxicity, and the unknown is 17% in UK, and almost similar in US. And in Germany it is hepatitis B, and is also hepatitis B and acetaminophen both dominate in Germany. And Japan it is hepatitis B infection. Bangladesh it is hepatitis E virus infection. If you come to India, hepatitis B and E constitute for almost around 60% in India, and unknown is around 31%. Hepatitis A is around 2, and others is 7. So if you calculate these, approximately around 60% is because of the infections with the hepatitis. So we have in India we have a robust vaccination system for the hepatitis in all the patients. So specific treatment. Ultimately, for acute liver failure, identifying the cause is the most important thing for the treatment for the success of the patient. But ultimately, once the patient has developed a failure and has encephalopathy, how much the chance of recovery is less even if you start on a specific treatment. The steroids, autoimmune hepatitis. Steroids are the treatment of choice for autoimmune hepatitis, and the steroid trial in suspected severe AIH is an established practice and can be effectively if given early. Its role is not clear when acute liver failure is developed. Significant risk of infection. The presence of jaundice, encephalopathy, and high NR are associated null response to steroids. So, if the patient is having a jaundice, encephalopathy, and high NR, then the response may not be good in a patient in the late stages. That is in the late stages. So here we need to suspect and we need to give a treatment early, and we need to basically to identify these patients is the most important. Hepatitis B, acute liver failure secondary to hepatitis B virus infection can be related to primary infection or reactivation of the previous infection. Retrospective evidence suggesting that antiviral treatment can improve the prognosis of patients with severe forms of acute hepatitis or reactivation, or including acute liver failure presentation. Entecavir or tenofovir has a high efficiency in these patients, and as we join in our medicine and even the community, vaccination is given to these patients and to everyone, and also we have a system of tracking these patients with a needle stick injury in a patient who is having a, from the infection control point of view in the hospitals. For all the needle stick injury, we look into hepatitis B and also HIV infections to avoid hospital-acquired infections. So specific treatments for HDV and HBV co-infection or super-infection develops acute liver failure. So specific treatment for HDV are rare, but very poor prognosis, and in severe cases, liver transplantation remains the treatment of choice. So toxins. So these are Amanita is a mushroom toxin, which are mainly gastrointestinal symptoms like abdominal pain, nausea, vomiting, and cholera-like diseases, followed by a marked increase in serum transaminases, eventually ALF. So Mars and molecular absorption recirculating system and fractional plasma separation and absorption system might be used in these patients. Silibinin is a specific antagonist for these, but it also has to be given as early as possible once we identify 20 to 50 mg per kg per day, intravenously for 48 to 96 hours, or 1.4 to 4.2 grams per day orally. Penicillin G reduces the binding of toxin to amatoxin to plasma protein, that increasing excretion. N-acetylcysteine has also been proposed with the usual doses. Specific pregnancy related. So this is a spectrum of diseases like pregnancy related. Although uncommon, severe liver dysfunction during pregnancy may have a dismal prognosis. Preeclampsia, eclampsia is the most common cause of liver disease during pregnancy, caused by the vasospasm of the hepatic vascular bed. HELP syndrome, the manifestation of preeclampsia is associated with liver infarctions, large hematomas, hemoperitoneum, and acute liver failure. Acute fatty liver of pregnancy, a rare but potentially catastrophic liver disease, usually diagnosed during the third trimester and associated with high fetal and maternal mortality. Pregnancy interruption is a treatment option. Here, identifying the acute fatty liver of pregnancy, HELP syndrome, preeclampsia is a very difficult scenario in this patient, because these patients with a pregnancy with a deranged liver function test, some characteristic features of this disease is the acute fatty liver of pregnancy, the liver failure is more worse, and more commonly we see hypoglycemia in these patients for acute fatty liver of pregnancy. In other conditions, we don't see it. The HELP and these patients, acute fatty liver of pregnancy, these patients also go into the DIC. So it is very difficult to identify these patients. They may overlap with HELP syndrome. So this need to look into it. Acetaminophen intoxication is the most frequent cause of acute liver failure in US and UK. Effectively, we all know that N-acetylcysteine for improving the prognosis of patients with acetaminophen toxicity induced acute liver failure has been extensively evaluated in large series and controlled trials and suggested a significant benefit in terms of survival. So these patients, we have a standard protocol and NAC doses, where the standard protocol is given loading dose of 140 milligrams per kg and 17 subsequent doses of 70 milligrams per kg every 4 hours, and intravenously 150 milligrams per kg over 30 minutes, and followed by 70 milligrams per kg over 4 hours, followed by 70 milligrams per kg over 16 hours. Even if it is difficult to remember, just you can just put in your protocol book, and you can continue your treatment. Just give me 1 minute. Sorry for interruption. Loading dose of so this so supportive management. So first, initially we do identify the therapy. Supportive management is important, and also we need to identify the most common cause of liver failure. Supportive management. Acute liver failure patients usually present hyperdynamic circulation, and systematically inflammatory response plays a pivotal role. Proper fluid administration is necessary to improve the tissue perfusion, and vasopressors are required to maintain an arterial pressure and cardiac output. So there was a single trial comparing noradrenaline and terlipressin in liver failure patients. Terlipressin increased the cerebral perfusion pressure without changes in the ICP, along with a decrease in the brain lactate. So in Europe, most of the centers still prefer terlipressin compared with noradrenaline, and we specifically see in the liver patients, it is the terlipressin is almost equivalent to the patient with the sclerotherapy. So in a patient who is having alcoholic liver disease, definitely this helps, but in acute liver disease, how much it helps we don't know, but at the same time the different function, it is a vasoconstrictor, and it helps in this, specifically in the liver failures. So you can use noradrenaline in a patient who is in the shock. Ventilator support may be necessary in patients with impaired consciousness or those who has developed the development of ARDS. Approximately 21% of patients develop ARDS late in the evolution of the disease and mainly associated with the occurrence of sepsis. The use of PEEP can increase alveolar recruitment without raising ICP. Basically, we use a PEEP when it is necessary, and these patients' infections are one most common and can lead into the ARDS. So these PEEP, no, don't worry about the PEEP, because PEEP may not increase the ICP. The PEEP more than 15 also in various studies has mentioned that it increases the ICP. Otherwise, no need to worry much, because oxygenation is the most important, which is a strong killer of the patient. Acute kidney injury is described in up to 70% of patients and approximately 30% of the affected patients during RRT. And one of the these patients, when they have encephalopathy, I think CRRT scores better over SLED in these patients, specifically because of the brain aspect. Cerebral edema and intracranial hypertension accounts for 20 to 25% of the death and may contribute to residual neurological impairment after recovery. Pathogenesis. Incompletely understood cerebral edema, osmotic and hemodynamic abnormalities within the confines of the rigid skull. Glutamine, the product of glutamate by ammonia, which accumulates within astrocytes, osmotic stress. So here, and there is and also hyperperfusion leading to the loss of cerebrovascular autoregulation and cerebral vasodilatation. So there is cerebral vasodilatation and accumulation of glutamine accumulation in the astrocytes, and there is osmotic stress, and the cells swell up and then leading to the cerebral edema and increased intracranial pressure. So, do we have a different methods of monitoring? Treatment means almost similar to the regular ICP management, but let's discuss on this aspect also. Invasive ICP can be obtained through different approaches: intraparenchymal, microtransducers, and direct catheters, intraventricular, subdural, or epidural. Epidural is relatively safe, and intraparenchymal is a high risk of bleeding present, but it's very difficult in a patient who is having a neurosurgery patient. We can put safely, but in a patient who is having a liver disease, coagulopathy, acute liver failure, is very dangerous to put the catheters because they continuously lead to bleeding. Indirect non-invasive monitoring is TCD. Is one it mentions us as about the flow of the blood flow. CT-MRI are the late correlations, because once a patient has a infarct or a bleeding, they will identify it, but otherwise it's very difficult. Or suppose in the raised ICP, in the late stages, we can identify CT and MRI. ONSD measurement is one of the earliest measurement we can do in a patient, and this has a lot of advantages. We can do repeatability, and we can see the pressure in the patients, and we can measure whenever is required. But only thing is, observer bias is most important, and we need to look into that. Prevention and treatment of cerebral edema. Prophylactic measures: elevation of head end at 30 degrees, reducing stimulation pain, proper sedation is required. So lactulose has a potential to reduce cerebral ammonia levels, but its use has not been associated with an improvement in encephalopathy or mortality in acute liver failure. And we give it, but in a patient's the chronic liver disease, these lactulose the evidence has shown that may improve the encephalopathy, but there is no change in the mortality in these patients. LOLA, L-ornithine and L-aspartate, enhance ammonia detoxification to glutamine in muscles, so that less glutamine is available into the brain and lead to the edema. In a large RCT, it did not lower circulatory ammonia levels, reduce the severity of encephalopathy, or improve survival. Hypertonic saline. So treatment is hypertonic saline to increase serum sodium levels to 145 to 155. A rapid decrease in intracranial pressure was seen in the active arm, followed by a significant reduction in the cumulative incidence of ICH in an RCT. So hypertonic saline 3% 200 ml or 30% 200 ml boluses are advocated. Actually, we have a 3% saline, 100 ml we can advocate, or 200 ml we can give a boluses, and then we can or you can start an infusion of a 3% saline, and the ultimate goal is around 150 to 155. So you need to frequently monitor the sodium in these patients. So marital boluses are also effective for reducing ICP, but ultimately you need to monitor your target serum osmolality less than 320 in these patients. And hyperventilation. As you know that in a patient who is having raised ICP, hyperventilation, that is no hyperventilation doesn't mean that very low PCO2, it is around 30 to 35 in case of increased intracranial pressure. Vasoconstriction secondary to CSF alkalosis reduces vascular inflow and decreases ICP. Short-lived, and we cannot continue this hyperventilation, and which causes a cerebral ischemia. So in these patients where hyperventilation is present, in a patients, specifically neurosurgery patients, we can give a hyperventilation and until the patient go for a surgery. But in a patient who is having this hepatic encephalopathy, maybe we can give for few hours if it is a very raised ICP before going to the liver transplantation. But ultimately, this doesn't have much role in the patient, and there is a chance that these patients can have a cerebral ischemia. Hypothermia. Again, hypothermia reduces cerebral blood flow and entry of ammonia into the brain, decreases the availability of glutamate in the cerebral extracellular space, and diminishes anaerobic glycolysis. So, the role of a temperature reduction to 32 to 33 was associated with significant decrease in ICP. Interestingly, this is a retrospective study showed that therapeutic hypothermia had no impact at overall or life or lung transplantation free survival. There is a hypothermia over an ICP, no difference in the incidence of sustained elevation of ICP in intervention group and control group or overall. Mars extracorporeal support systems, molecular adsorbent recirculatory system designed to eliminate inflammatory molecules by employing albumin dialysis, reducing nitric oxide levels, and improving hemodynamic parameters. Improvement in systemic and cerebral hemodynamic variables, no survival benefit. And a hepatic assist is employs porcine hepatocytes contained within a hollow fiber bioreactor in randomized control, no advantage. So basically, there are a lot of systems like molecular absorption system, hepatic assist, and these have doesn't have shown to be much outcomes. So high volume plasma exchange has shown to improve transplant-free survival in an RCT, but most patients suffered from acetaminophen overdose, 54%. Usefulness in different cohort of patients is uncertain. So here, the high volume plasma exchange also is not much useful. So ultimately, in a patient with acute liver failure, the most important is liver transplantation, which is not responding to our therapy, and specifically in encephalopathy. And liver transplantation is single most important intervention to improve survival in the most severe cases of acute liver failure. But the limitations are organ shortage, severe clinical deterioration, severe comorbidities, and substance abuse. Survival rate 1 year is 84%, 5 years is 75%. United Network for Organ Sharing has analyzed 4 factors associated with poor outcome. One is age more than 50, requirement for life support, body mass index is 30 kg per meter square, and serum creatinine more than 2. So we all know that these factors, if the patient is 50 years on life support system, either on a ventilator or a vasopressors or a obesity and renal failure, this increases the mortality in these patients. Several prognostic tools have been developed in order to predict mortality and need for liver transplantation. King's College criteria, the MELD score, Apache score, and SOFA score are some of the most commonly used scoring systems. So King's College criteria, so it has 2 criteria. One is acetaminophen induced acute liver failure, arterial pH less than 7.3 after fluid resuscitation, or all the following variables like PT more than 100 seconds, serum creatinine more than 3.4, a grade 3 or 4 hepatic encephalopathy. Non-acetaminophen induced acute liver failure is PT more than 100 seconds, or 3 of the following variables: non-A and non-B hepatitis, drug-induced or indeterminate etiology, time from jaundice to hepatic encephalopathy more than 7 days, age less than 10 years or more than 40 years, and prothrombin time more than 50 seconds, and serum bilirubin more than 17.4 milligrams per deciliter. Liver transplantation. So in a meta-analysis, the diagnostic yield of King's College criteria was evaluated and compared to the MELD score. King's College criteria seems to be more accurate paracetamol toxicity, and MELD score is a better prediction of non-paracetamol toxicity. The SOFA score seems to be useful and comparable prognostic tool in acute liver failure. So as we all know that the organ scoring systems, failure systems, and lactate has been correlated with the prognosis in acute liver failure. And the Alfred model, prognostic model in India, hepatic variables over 3 days. Hepatic encephalopathy, the persistent and progress to grade more than 2, INR more than 5 is 1, arterial ammonia 2, serum bilirubin 1. So on a day 3, score of 4 is associated with 90% mortality, a score of 1 is associated with about 5% mortality. So these 4 systems like encephalopathy, INR, arterial ammonia, and bilirubin. So these are the 4 important systems where the score of 4 is associated with 90% mortality. So in a patient who is on hepatic encephalopathy with acute liver failure, see here hepatic encephalopathy INR will be but not more than 5, and arterial ammonia may be high, and the score is very high for hepatic encephalopathy and arterial ammonia. So their mortality might be very high in these patients. So hepatocyte transplantation, the cell transplantation harvested from the liver grafts not suitable for liver transplant from neonatal donor, then they are isolated and directly administered to the portal system or the splenic artery injection. In metabolic diseases such as Guillain-Barré or the familial hypercholesterolemia, significant improvements have not been reported. However, these metabolic improvements are transient and most patients would need liver transplantation as a definitive treatment. In acute liver failure, recovery without liver transplantation is uncommon. Stem cell transplant can be performed employing embryonic stem cells induced pluripotent stem cells, hepatic progenitor cells, hematopoietic stem cells, and mesenchymal stem cells. This can be obtained from bone marrow, adipose tissue, umbilical cord, or amniotic fluid, and its differentiation to hepatic cells can be induced. So, mesenchymal stem cells can improve liver function, decrease hepatocyte apoptosis, and promote hepatocyte proliferation. In a recent randomized controlled trial, including 110 patients with hepatitis B-related acute chronic liver failure, infusion of mesenchymal stem cells was associated with increased 24-week survival. So I think I don't have any idea on this stem cell transplantation. I think if anybody has an experience on this, can throw light on this topic. The use of decellularized 3D extracellular matrix scaffolds for whole organ engineering requires the decellularization of the human or animal organ, which generates a scaffold to allow a decellularization process with parenchymal and non-parenchymal cells, hepatocytes, cholangiocytes, and endothelial cells. Genocyte scaffold porcine so could become a promising alternative to conventional liver transplantation, although several difficulties and technical shortcomings still need to be overcome. So there are 3 questions in this. If somebody can answer, that will be great. So all are criteria to diagnose acute liver failure except jaundice, coagulopathy, hepatic encephalopathy, and ascites. Residents can post. Answer. Perfect answer. So ascites is not there. So jaundice, as we have discussed, jaundice, coagulopathy, and hepatic encephalopathy. Okay. So which is incorrect about treatment of acute liver failure? N-acetylcysteine is effective for paracetamol-induced acute liver failure. Acute liver failure due to viral infection has no specific treatments in acute stage. Pregnancy-induced acute liver failure cannot be managed with supportive treatment without interrupting pregnancy. Steroid is very effective in autoimmune hepatitis once acute liver failure has established. Answer, please. Okay. So, basically, N-acetylcysteine is a choice for paracetamol-induced acute liver failure. And few of the virals doesn't have any specific treatment. And pregnancy-induced acute liver failure definitely needs a termination of a pregnancy. And steroids is very effective once it is in the early stage of the disease, but once it is a late stage of the disease, it is not much effective. During treatment of acute liver failure, which is correct? Antibiotic prophylaxis is recommended as sepsis is very common. Prophylactic blood component transfusion is best way to prevent bleeding. Intracranial hypertension is responsible for 1/3 of the mortality. Hypothermia is shown to reduce mortality consistently. Answer, please. Three. So during treatment of acute liver failure, which is correct? Antibiotic prophylaxis is recommended as a sepsis is very common. Prophylactic sepsis is common in these patients, acute liver failure, and prophylaxis blood component transfusion is the best way to that is wrong. And intracranial hypertension is responsible for 1/3 mortality, yes, and hypothermia is shown to reduce mortality consistently, that is wrong. Okay, so the answer goes to 3. Okay, thank you all, and you can share your experiences or any questions we can discuss. Thank you. Yeah, open for discussion. Dr. David, are you available? David sir. Satish sir. Satish sir.
Sir, good morning, sir.
Sir, good morning, sir.
Good morning.
David ki
అయిపోయిందా?
అయిపోయిందా? డేవిడ్ కొంచెం మైగ్రేన్ ఉంది, సో మోహన్ సార్ కూడా జాయిన్ కాలేదు. మోహన్ రావు గారు బిజీ ఉన్నారు. సార్, యువర్ ఎక్స్పీరియన్స్ ప్లీజ్ లెట్ ఎవ్రీవన్ నో, సార్.
అంటే recently I have one patient who is having a recurrent like acute on CLDs, but the thing is unresolving encephalopathy within 10 days. 3-4 times he got admitted.
Dinesh.
Ammonia is simply around 120-110, but patient is severely encephalopathic, and we are able to manage conservatively, and we involved a hepatologist and a liver transplant surgeon. And the issue for recurrent this thing is there is significant collaterals out there. So because of this collateral circulation, there is a lot of these things have gone into the cerebral circulation, and they are suspecting that ultimately they requested us to do CT venogram or something.
సార్ వినపడట్లేదు సార్ సరిగా.
Things is not encephalopathy will cause worsening. Sir, ఇప్పుడు hello.
Now better, sir.
See, it is like what I understood is whatever we understood previously when that we attempt to go for a tips, patient that significantly might go into encephalopathy. This is like natural tips like thing. There is a significant establishment of the collateral circulation is the culprit for him to go into recurrent encephalopathy. That's what I understood with that case, and I want to share with you all.
Thank you, sir. And basically most of them, sir, what the patient who is having acute liver failure or acute and chronic liver disease, I do see a lot of actually I'm seeing a lot of alcoholic liver disease patients now. So there maybe they might be what they might be drinking, we don't know, but not to label the patient who is taking very less alcohol or less duration. This we may miss identifying the other causes, but labeling every patient as an alcoholic liver disease and living is not a good thing. I feel this is my opinion, sir. Because alcoholic liver disease to label, I think he has to take 50 to 60 grams of alcohol per day, that to around 12 to 15 years or something is there, unless he has some systemic diseases or so, then they may develop the disease. So I think just labeling than that, I think we need to investigate into other factors also. Like if the patient is having liver disease, they may end into a treatable disease.
Srinivas Zekina, nice presentation. Srinivas.
Sir, thank you. Chappan, sir.
Yeah. What is your experience in Mars?
Mars, sir, Mars. Actually, I used 2 to 3 cases, Mars. But see, this is only to, it's a bridge for the transplantation, sir. It is nothing to do with the disease control.
So once the patient lands in the hepatic encephalopathy grade 3 to 4, what are the options we do? And that means most of the whatever we are giving is symptomatic only. We have to means is there any? And that means in a coming you telling the stem cells like that, anything useful in that situation? Because most of the time once the patient is landed hepatic encephalopathy grade 4, now we most of the time we lose the patient.
Yes, because these patients, we lose the patients very faster also. I don't have any idea on that, sir. But I think what we can do is, like we can, is a bridge we can use Mars or high volume plasma exchange we can use only as a bridge, not as a therapy. And so that they can go wait for 2 or 3 days for a transplantation. And I think Medanta, do they do any such therapies because it is famous for liver? Srinivas?
Sorry, ఏ థెరపీ సార్?
Molecular.
మార్స్ ఉంటుంది సార్, థెరప్యూటిక్ ప్లాస్మా ఎక్స్చేంజ్ చేస్తారు. సిఆర్ఆర్టీ ఇస్ కామన్. కానీ మార్స్ నెంబర్ అయితే తక్కువ. యాజ్ యూ సెడ్, మార్స్ నెంబర్ ఇస్ లెస్ బికాస్ ద అఫోర్డబిలిటీ ఆఫ్ ద సర్క్యూట్ ఇస్ వెరీ లెస్. 2 lakhs to 2.5 lakhs ఉంటుంది సర్క్యూట్. సో ఇట్ ఈస్ నాట్ వెరీ ఈజీ ఫర్ ద family to convince and get some result there.
If suppose Srinivas, if patient is affordable, how long we can manage with mask?
Sir, ఒక సర్క్యూట్ మీకు 24 hours వస్తుంది.
And generally, is there any idea like kidney failure? As long as that donor comes, now they will manage with CRRT or HD. Like that, is there any thing is there? I don't know.
Patient complete గా decompensate అవ్వనంత వరకు మనం వెయిట్ చేయకుండా, if you start in an initial stage, then we can prolong the patient for at least 3 to 4 days. That is not a problem.
Okay.
That the patients మన దగ్గరకు వచ్చినట్టు అది మొత్తం డీకంపెన్సేట్ అయ్యి దే ల్యాండ్ ఇన్ మల్టీ ఆర్గన్ ఫెయిల్యూర్ లోనే వస్తారు కదా. ఇఫ్ దే డోంట్ కమ్ ఇన్ మల్టీ ఆర్గన్ ఫెయిల్యూర్ ఆల్సో ఇన్ 24 hours దే డెవలప్.
అంటే ట్రాన్స్ప్లాంట్ సెంటర్స్ కి కొంచెం వేగంగానే వస్తాయి సార్. సో ఇఫ్ దే ఆర్ అఫోర్డబుల్ వీ కెన్ చేంజ్ సంథింగ్. అంటే ఎర్లీ స్టేజ్ లోనే, లైక్ హైపర్ అక్యూట్ 4th day 5th day దే ల్యాండ్ అప్ ఇన్ ఎన్సెఫలోపతి అండ్ డైరెక్ట్లీ కమ్ ఫర్ when there is a proper communication and all those things వస్తా ఉంటారు చాలా మంది.
We have done one Apollo lo, we have done hyperacute we have done one liver transplantation. We don't know the call, and we have done it, but I think ultimately even in hyperacute, do you try, suppose if you don't identify, do you do a liver biopsy and see the causes? Srinivas, మీ దగ్గర ఏంటి ప్రోటోకాల్?
సార్ అది అంటే బయాప్సీ అయితే చేయదు సార్, బట్ దెర్ ఈస్ అంటే పేషెంట్ హూ ఆర్ ఎలిజిబుల్ ఫర్ ట్రాన్స్ప్లాంట్స్, అంటే ఈ వీళ్ళ కోసం అక్యూట్ లివర్ ఫెయిల్యూర్ వచ్చిన వాళ్ళకి దెర్ ఈస్ అ ప్రోటోకాల్ ఆఫ్ బ్లడ్ టెస్ట్ అండ్ బ్యాటరీ ఆఫ్ టెస్ట్ which we send so that we first completely evaluate the treatable causes. Generally, hepatitis A, we wait for some time, at least for 3 days, and there is an age criteria after which we take up for a transplantation. Unknown cases, unknown అంటే except పాయిజనింగ్ కాకుండా అన్నోన్ ఏమైనా కాదు అంటే మీన్ నార్మల్ గా బ్లడ్ టెస్ట్ లో తెలియట్లేదు అంటే విల్ గో ఫర్ ట్రాన్స్ప్లాంట్. పేషెంట్ ఈస్ నాట్ రెస్పాండింగ్, సో we used to go for transplant. Biopsy is a very risky thing, and I mean generally avoid చేస్తాం.
There is one patient, having liver failure. What is the hospital in Hyderabad for transplant? Hello?
Hello, sir. చెప్పండి సార్.
Hello?
చెప్పండి సార్, వింటున్నారు.
He developed infection. He developed infection progressed on elevated, so they donor is there, but they are waiting to treat the infection. Actually, liver transplant, liver is the most acceptable.
సార్ నాకైతే వినబడట్లేదు, అందరికి వినబడుతుందా?
లేదు సార్, వినిపించట్లేదు.
Hello?
సార్ ఇప్పుడు వినిపిస్తుంది.
Okay. So once patient ready for surgery, if we develop infection, can we go ahead and wait for to treat the infection?
రెడీ ఫర్ సర్జరీ అంటే నాకు అర్థం కాలేదు సార్. ఇప్పుడు ద పేషెంట్ ఈస్ పోస్టెడ్ ఫర్ లివర్ ట్రాన్స్ప్లాంటేషన్. ఓకే, యూ మీన్
Yeah.
సో వాట్ ఇన్ఫెక్షన్ ద పేషెంట్ డెవలప్డ్?
Actually, I don't know. They said there is infection forecast on elevated developed fever. So we'll wait a few days until you treat the infection.
Patient with a liver failure and a patient with an infection, that liver failure patient developing sepsis is very difficult to identify because they have hypotension, they have vasodilatation. The patient will be in shock. The patient, so all the sepsis features are only present in hepatic encephalopathy.
And how will you differentiate? Is it liver failure is related or sepsis related hypotension?
It is difficult. Only thing is what we can.
Then can you go ahead for do transplant in that case?
Transplant అంటే మరి ఇప్పుడు పేషెంట్ is worsening కదా. ఇప్పుడు ఇన్ఫెక్షన్ అని how you identify means because patient has worsened with a multi-organ failure.
Yeah, worsening of counts are elevated and hypotension, fever, persistent fever, procalcitonin is elevated. So at least some few features of elevated sepsis markers, symptoms, all these things. Once patient is okay, anyway symptoms are there, but deteriorates, that may suspect sepsis, worsening.
Better to do my opinion is better to do a PCR test for that. And PCR rapid
PCR panel.
PCR panel పంపించి చెక్ చేసుకుంటే బెటర్ ఏమో అనిపిస్తుంది. ఎందుకంటే ఎఫెక్టివ్ గా అంటే we have to wait at least for 48 hours. Sudden development of fever, shock or other organ failures, I think it's a double edge. Patient, if you don't do transplantation, patient is going to die. If you do transplantation, patient you may have a liver transplant success, but the patient may die with an infection
due to sepsis.
ఎవరు తీసుకుంటారు సార్? సర్జన్ ఎవరు చేయరు కదా.
అదే that's why they said we will wait, but we don't know, patient may deteriorate and he will die also.
Patient ఏడ బతుకుతారు సార్?
And these infections are also very severe and multi-drug resistant bacterial infections will develop, even fungal infections will develop.
Yes, yes.
Okay, Anna, very nice presentation.
Thank you, sir. Thank
Okay,
you.
yeah. There are no questions, and shall we close this? Anna,
Srinivas
please
sir,
share
నేను ఫోన్ చేస్తాను.
personal గానా?
Yes.
అవును సార్.
Yes,
ఇక్కడ
sir.
అడగకూడదా?
వద్దు.
Yes, sir. Yes, sir.
Okay,
Sir,
Anna.
no questions will close, sir. Thank you, sir.
Okay, okay. Please share the PPT, Anna.
Yes, sir. Yes, yes, sir. Already I sent to you also. I'll share right. Right, sir.
Okay, Anna. Thank you. Thank you so much, and thank you all the audience. We will close the session.
Thanks.
ఇదేనా రావడం లేదే నిన్నే వచ్చి ఆ పక్కన పండగ ఇంట్లో పడుకున్నా ఇది సరదాగా అన్నానండి ఏ సీరియస్ గానే అమ్మా ఎక్కడ అదిగో వస్తున్నారు మామయ్య గారు కన్ను పెట్టండి మరి గిఫ్ట్ ఇస్తావా ముసలోడే కానీ కూడా మామయ్య గారు ఎప్పుడు సంక్రాంతి వచ్చారు మామయ్య గారు చిన్నప్పుడు